Welcome back. Let's talk about aortic dissection. The aorta, just like all blood vessels, has three layers. The most inner layer, which is called tunica intima, the middle layer, tunica media, and the outer layer, tunica adventitia. Sometimes a separation or a dissection between these layers can occur. And in case of the aorta, where the blood pressure is very high and there's a lot of blood can seep into this crack and get in between these layers. And this presents as an enlarged segment of the aorta. It is commonly referred to as a pseudoaneurysm. While a true aneurysm would have a stalk or a balloonish shape, a pseudoaneurysm, as seen in aortic dissection, is more diffused and appears as an enlarged area. Of course, all of this blood that is accumulated in between the layers can leak out as soon as the outer layer is penetrated. And this is, of course, life-threatening. We classify aortic dissection diseases into two categories, either Stanford type A or Stanford type B. Stanford type A is aortic dissection that occurred in the ascending aorta, and Stanford type B is dissection that occurred in the descending aorta. Another classification that you might see in the exam is known as the Dubacki classification, and it has three types. Type 1 involves the ascending aorta, the aortic arch, and the descending aorta. Type 2 involves only the ascending aorta, and type 3 involves only the descending aorta. A telltale sign in aortic dissection is uneven pulse between the two arms. This is also referred to as radio-radial delay. The blood pressure between the two arms will also be affected. If you did a chest X-ray, you'll see a wide mediastinum. And if you performed a contrasted MRI or contrasted CT, you will see the separation between the true and false lumen. It is commonly caused by hypertension, or genetically by Marfan syndrome, and sometimes it's just simply idiopathic. The initial test is a chest X-ray, and if this showed wide mediastinum, you should confirm it with a CT scan if the patient was stable, or ultrasound if the patient was unstable. Treatment of type A is always surgery, and treatment of type B sometimes is surgery, but sometimes it's just beta blockers. And here's a small quiz. What is the genetic cause of Marfan syndrome?